Okay, so here is my case study. I have an elderly female presenting with ascites. She has a BMI of 48. That's really high BMI. She's a big girl. Hard to tell how big she is though with the amount of ascites she has. She could be having 20 pounds extra in weight. Nursing diagnosis, I have to figure out how she got the ascites and what we're going to do about that. But with this case study, I found that there's a lot more to dig into. And so that's why I'm making this video. Over here, I've got a list of all the things she's diagnosed with and the pertinent labs that go along with this. Now, before I get into this, I have to discuss the bean, the spleen, and the liver. Yes, talking about grandma's house for dinner. What I want to talk about first off is the kidney. Let's talk about the bean here. Its primary role and function is to clear out the system of toxic waste, homeostatic fluid balance, and of course, blood pressure. We remember that it can give off erythropoietin to increase red blood cell count, and also from the GJA apparatus, it can initiate renin release that causes the RAS system. Okay, that's out of the way. We got that one. Blood pressure, filtration. Let's go over to liver. Liver's got up to 500 different functions, so let's just nail it down to filtration and metabolism. What happens basically is blood goes into the digestive system, into all these other systems, and then flows, free-flowing, into something called the portal system, which we didn't learn about in A&P, and goes into the liver for filtration and metabolization. So when we talk about drugs, medicines, bad food, metabolic waste, it gets filtered out by the liver and then sent away. Also, it has bile production, which is great for lipid absorption. That's their liver. Over here's the spleen. We don't talk much about the spleen. And I don't know why, because the spleen is actually pretty important. I guess you can cut out the spleen and still live, so we don't consider it important. The truth of the matter is up to 25% of the spleen has macrophages and white blood cells working on it. It is a lymphatic organ, therefore has everything to do with the immune system, okay? What we talk about with the spleen all the time is the filtration of red blood cells, but it does more than that. Yes, red blood cells go to flow in there, and it's going to filter out any disease, old, decrepit looking blood cells. That's why we have sickle cell anemia a lot of times, the sickle cells get caught in there. And also, it has platelet sequestration. So it'll hold on to platelets and dispose of those as well. How these two work together, we know that when we break down red blood cells, then we have something called heme, bilirubin, goes in the liver, all that jazz, right? But I want to talk about my patient. So the very first thing that she tells me when I come into the room is she has been diagnosed with ITP. A question I should have asked her, perhaps, was at what time in her life did she get diagnosed with ITP? I did not ask. ITP, what is it? It's immune thrombocytopenic purpura. Yes, there was evidence of bruising on her forearms, on her extremities, which would be indicative of thrombocytopenic purpura. The thing with this one is we don't really know what's going on. In my research, it used to be called idiopathic. Now they think it's immune. Well, I just said that 25% of immunity occurs in the spleen. So chances are it's happening within the spleen where it's destroying thrombocytes, otherwise known as platelets. So if this is the case, what you're going to see here is you're going to see a decreased amount of platelets, right? Which we see over here somewhere, right here, decreased platelets. You're also going to see something called hypersplenism. And that just means that the spleen is working overtime. And why not? We have this immune system that's going to be working overtime on destroying all our platelets. At the same time, that is going to lead into this guy called splenomegaly. We'll pretend that's a megaly. Splenomegaly. So we've got hypersplenism and splenomegaly working hand in hand. We're working harder, we're working bigger. If we've got splenomegaly, we can also probably decrease red blood cells. RBCs. Can I spell? No. So far, so good? Good. Of course, hemoglobin and hematocrit's also going to follow with that. Now moving forward. Let's go back to the kidney. She has stage 3, 1, 2, 3, CKD. All right? Chronic kidney disease. How did she get the chronic kidney disease? Another question I never asked, but I probably should have, was this DM. At what point in her life did she get diagnosed with diabetes mellitus? I'm going to say, because of her BMI and just from brief talking with her and age group, she probably did not have the best diet. And I'm also going to put in there, she probably didn't have the best lifestyle. Okay? So that's where it all begins. Diet lifestyle is going to lead to the diabetes mellitus, DM2. And as we know what DM2 is, if you're uncontrolled blood glucose, it's going to wreak havoc on your small blood vessels. And voila, we've got tons and tons of small blood vessels in our kidney. Now, how it really works is, okay, so one nephron might go down, that's fine. The blood will just shunt off to the next available nephron that's working. And the body will tolerate this for a certain amount of time. But what ends up happening is the next one shuts down, the next one shuts down, and that's how you start getting chronic kidney failure. And that's how diabetes mellitus does this. It breaks down the vessels, so you get ischemia, and then finally death to a nephron. So, okay, that answers stage 3 CKD. I'm going to check these off as I go through. We've done that one, we've done that one, we've done that one. Now she tells me recently she's been diagnosed with cirrhosis. Well, what the heck? Where did this one come from? And what is the relationship to everything? Obviously, cirrhosis was in here because that leads, in essence, to the ascites. But we're not there yet. First, I want to talk about, did she drink alcohol? And from when I talked to her, she denies ETOH. And she just didn't seem like that kind of lady. But she denied donuts and sitting on her butt. No, she didn't deny any of that. So there's something else called NAFL, non-alcoholic fatty liver disease. So this is going to cause damage, injury to the liver. Okay. This is where things get messed up. This is really a lot of chicken and egg kind of situation. Going back to the spleen, from my research, and there's still a lot out there that we don't know, is when the spleen is overactive, when we're doing hypersplenism, we're going to have a lot of cytokines being released that are going to go through the portal system directly over to the liver. And what they're saying is that some of this stuff actually affects the liver in a negative way, and if the liver is already injured, it's going to compound the injury. So then what happens is we start getting back up from the injury, from the liver that's not working so well, and it's going to go out into the systemic backflow. And this is what's going to create your portal hypertension. What is portal hypertension? This is a venous system through here. And so as blood's trying to rush into the liver and it can't get in there anymore for filtration, it's going to start backing up to all these other systems. And it really starts backing up into a lot of other systems. That's where you're going to get hemorrhoids, you're going to get, esophageal varices. That's a very serious condition that's life-threatening, and you got to look at it right away. And so we have that going on, okay? So now we have a diseased kidney, we have fatty liver, and we have splenomegaly because of this ITP over here. What the doctors, let me skip a couple things. What the doctors want to do in this situation is do this procedure down here called TIPS. And what do we learn in nursing school? We learn big words. That one's going to be your transjugular, intrahepatic, portosystemic shunt. Big fancy word. What they're going to do is they want to shunt some of the blood away from the liver to go back into the system so we don't get this portal hypertension. Sounds all good and all, except for one thing, is that the liver is prominently there to clean out toxic waste. If we're not doing that, then we're going to have more waste build up. But it's either that or death. If that doesn't work, we're going to go over to splenectomy. Okay, good enough, right? Sure. We have a couple more problems here. We can't operate yet. Why can we not operate? Oh, let's talk about this real quick. Let's talk about the elevated BUN, I know it's BUN, and creatinine levels. These, I would say, indicative of what? My CKD. Okay? I got increased T-billy, total protein, and albumin. This is going to be because our liver is not functioning. RBCs, HB, hematocrit, platelets. This one's going to be a few things. So I'm going to hold the phone on this one. What we know about kidneys is erythropoietin, but what we don't know, and no one's ever talked to us about, is something else called TPO. And that's thrombopoietin. Okay? Kidneys produce it, and so does the liver. But listen, if these are both compromised, our TPO is going to then be decreased. So we have a decreased amount of TPO going out. So not only do we have this immune thrombocytopenic purpura that's destroying all of our thrombocytes, we're now at an impaired level of production of thrombocytes. So we're just getting totally beat up. And we can see that right over here with our extremely low platelet count. Why does this matter? Well, this matters because if we want to do TIPS, this is a medical surgical procedure. We cut our patient open, our patient will bleed to death. Stop right there. Let's talk about the ascites. I still haven't gotten there yet. Why do we have ascites? Okay, so the liver is impaired. What does the liver produce? Albumin. Right? If the liver is not working right, then we have a decreased albumin. And what we remember from A&P is albumin is the main factor as far as oncotic pressure. So now our blood vessels no longer have the albumin needed to create that oncotic pressure. The fluid is going to leak out interstitially, and boom, you have ascites and edema. Primarily ascites when we're looking at cirrhosis. Oh, but I haven't got the cirrhosis. I missed that part. So we started off up here with a little non-alcoholic fatty liver disease. But as this is getting beat up over here, as this isn't performing well over here, because if we are not clearing out all of our toxins through our kidneys, it's going to back up into our bloodstream and make the liver work overtime. So liver's getting damaged all over the place. And this is why this one bothered me so much, was like, which chicken came first or which egg came first? Cirrhosis. Let me spell it right. Cirrhosis. So now we have cirrhosis, which is just the buildup of fibrous tissue, fibrous scar tissue in the liver, which makes it not work so well. So now we have cirrhosis, we have decreased albumin, decreased TPO, we have ascites. What about the thrombocytopenia? Well, if I don't have TPO, I cannot make thrombocytes. And I still haven't solved this guy over here, thrombocytopenia. And this is all going to be indicative right here. These levels right here, I can't cut my patient open. If all else fails, we're going to go over here and we're going to just cut out the whole spleen, called a splenectomy. It's one way of increasing our platelet count back up, but not the best course of action. As you can see, this is just a cursory look at these things, at the portal system. That's a huge doozer that we haven't gone over. And there you go. That's my presentation on the pathology of my patient. Cheers.